Hello, everyone, and thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a quick few housekeeping items. The Private Practice Simple Solutions program is a series of rapid learning cycles designed to provide opportunities to implement actionable changes that can immediately increase efficiency. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to carefully review this notice.
Thank you, Symbol. I'd like to thank our audience for joining us today on this webinar, and I'd also like to thank Dr. Lockhart for joining us as well. Obviously, we have Dr. Lockhart's frozen image, which is a very, very nice image of him. Hopefully that'll get the live picture will get back online soon, so we're working on that. But welcome, Asa. It's a pleasure to be talking to you today. And if you don't mind just introducing yourself to our audience so they know your background and your experience level.
Yeah, I'm Asa Lockhart, a practicing anesthesiologist for a little over 40 years clinically. Went back on MBA in the late 90s and founded Golden Caduceus Consultants. At this point, we've worked with about 219 practices now in 41 states. And we do benchmarking, fair market value, staffing, budgets, strategic planning. So just, a number of services that the practice might need. Sometimes our simplest deal is to keep everybody from killing each other at the end of the meeting. So facilitating solutions is like what we think we like to do. So thank you.
Awesome. So to our audience members, please go ahead and put in your questions in the Q&A dialog box on the left-hand side of your screen. If you have any questions whatsoever, we can ask Dr. Lockhart. Obviously, he has a breadth of knowledge and a lot of experience dealing with the revenue cycle. So let's kick it off initially. There was a question that came in on our discussion board after our last webinar, and that was, and I think this will resonate with a lot of our listeners today, is that the question was, we have an outsourced billing company. How do we know that they're doing a good job and all the implications thereof? So Dr. Lockhart, what are your thoughts on that?
I think what you need to do is to benchmark your practice. And in benchmarking, you would look at the key performance indicators. You'll hear the acronym KPI. And look to see how are they handling the revenue cycle as far as the percentage of money on a claim that should be captured. How are they doing? And compare that to your peers. Look at your basic billing processes. But with the billing company, it's looking to see the net collection percentage of the potential, not your charge, but of the potential revenue that could be captured on a claim. What percentage of it should they have captured? Now, it's not going to be 100%. You have charity care and small balances and a number of things. But in comparing your practice to peer practices, and you wouldn't compare an anesthesia practice to a primary care practice. So that would be my, that would be your first step. And determine, is the billing company doing a good job or are they performing a suboptimal? So thank you.
Yeah, what would you say, Asa, of the frequency that you would need to do this? I know it probably takes a lot of time to initially understand the situation, but hopefully, as things go along and you're more comfortable with looking at the KPIs, how often do you think you should review that in a practice?
It would, to some degree, depend on the size and the complexity of the practice. Excuse me. A large practice that has more robust infrastructure with a practice manager, the practice manager should be looking at it monthly, and they would look to see at the accounts receivable, how that's being handled. They would want to kind of check payment accuracy by payer, ideally. But you at least probably once a year, but most practices, I would say, would do it quarterly. If it's a larger practice and they have an executive committee, they're probably looking at monthly reports. A good company should be able to give you monthly reports. The dirty little secret is that they may bury it in a ream of paper. And so what you want to request from your billing company, or even if you're insourced, is a dashboard that has a simple kind of one-pager amount of how they're handling the accounts receivable, how the net collection percentage, what is the overhead, trailing those. But so you might do kind of a quick dive monthly, but do really a deep dive probably at least once a year.
Great. Yeah, I think you can look at those numbers, and you spoke about benchmarking. Where can we find information about how we're doing in relation to our peers? So where can we find information about peer practice KPIs?
You may be able to get some information from your professional specialty society and some of the subspecialties. If it's a large, may have some good data. I would say that the average practice that the go-to is the Medical Group Management Association, or MGMA. They put out compensation surveys annually. They have a cost survey, which is where, from a practice management and the revenue cycle, that's where I go. That particular survey is the one that I go to for that type of information. But they also have surveys on your practice over. That's more oriented towards a practice manager rather than a physician. So, but MGMA is good and tends to reflect a lot of primary care practices. Now, there's the American Medical Group Association. There are some of the surveys that tend to be oriented to more multi-specialty clinics and academic clients. So, but for the average private practitioner, the MGMA databases are hard to beat. And if you participate in some of the surveys, at one time, you could get the results of that survey free or for a discounted cost. So you'd have to check with them on the particulars. But there is some benefit, and the more people that respond, the better quality the information will be.
Great. Thanks for those resources, or that resource. I think that could be proved very valuable for our audience members. Turning towards the steps in the revenue cycle that we sort of went through on the last webinar, I want to address the first step that we talked about, which is the patient registration step. We know that a lot of the times there's missing or incorrect demographic information. And that can lead to claims denials, et cetera. But what other issues have you found that could derail the process during this step?
Well, be sure to inquire if there's been a recent job change, especially in your larger private employers, but especially your governmental employers, because a lot of times they will submit their enrollees or they're covered at the end of the month, and it may take sometimes another month before that it actually is entered on the payer cycle. So even though it may say the Blue Cross Blue Shield, for instance, the actual payer may be Texas Instruments, and they have what's called a TPA, or a third-party administrator function. And so if the insurance company itself is carrying the insurance, which is actually a minority percentage, then it'll be current. But if it's a third-party administrator, it could very well lag a month. So that becomes kind of your first early warning sign. If there's been a recent job change, be prepared to kind of watch that claim a little bit closer than someone who's been in a more stable employment situation.
That's a great tip. I think I've had that happen a couple of times in my practice, where folks have changed jobs, and all of a sudden we didn't know what was going on with their insurance, and it took a little bit of time to figure that out. So that's a great point.
And see, they may actually have an insurance card that shows them to be currently insured. So it's awkward for the payer as well because it makes them look bad. And so it's just that it's not particularly bad faith on anyone's part. It's just the slow wheels of bureaucracy sometimes turn not all that rapidly.
Right, and transitions are always hard for to sort of get stabilized after a little bit for anything that we do, of course. Moving on to another audience member question, I think the question is what's the best time to renegotiate with health plans related to payer contracts to increase reimbursement, and how should this be approached? I think I'd like to talk about this sort of in the lens of the revenue cycle management structure. Is there anything in the revenue cycle management that informs when to sort of negotiate with health plans? What's the best timing? Are there KPIs that you can use in the revenue cycle to approach those health plans?
Well, one of the things, if you look at the accounts receivable, if 15% of your charges, not patients, but if 15% of your charges are, say, with United, then roughly 15% of your AR should be with them as well. And so in the negotiation, you're giving them, in a managed care negotiation, you're giving them a discount for delivering volume, and you're giving them a discount for provided, reasonable payment cycles. And so if they are not delivering the volume, if they are slow paying, let's say that your accounts receivable, that one of the key performance indicators is called days in AR. So if you had about how many days worth of charges are in your accounts receivable, and I'll just use the numbers. Let's say that your days in AR for your whole practice is 30, but your days in AR with Aetna are 65. Then in your negotiating or in your negotiations, one of the things that you want to get out of the negotiation is that you would want that company to bring their days in AR down to the benchmark of other payers. So that would be, one aspect that you might take a look at.
Right. I think we're always looking for ways to get leverage, and I think that you bring up a great point. If the payer is not performing against other payers, I think that is a point of leverage. So I think that's a great value add to looking at your revenue cycle when it comes to negotiations.
And see, one other thing I would throw in is looking at clean claims. Not for the person who was with the previous employer or so, but of claims that have gone through the cycle on the clean claims. How is a particular payer handling those? And if you have the same billing staff and one company's clean claims are 80% and most of your practice is at 95%, then that payer is playing games with you. And so you would want to have some incentive for them in order to get their discount that they would match the clean claims percentage, because that if it's clean claim and they're having to refile, those are your employees, who are having to take that additional time. Another caveat is the call center. From a staffing standpoint, if most of the payers, the whole time is 7 minutes and one of them's 35 minutes, then you would want to bring that into the negotiation, not so much because it increases your revenue, but it will increase the job satisfaction of your employees and help with burnout, both for you and your employees.
Well, I'm glad you touched on the sort of billing staff and revenue cycle staff in your practice. I wanted to dive into that further. I know we just mentioned how to sort of manage the payer side of that. But how do you monitor and incentivize your billing staff or your revenue cycle staff in your own practice to improve on their clean claims and denials decrease performances?
One of the things that I mentioned a few minutes ago was the MGMA, Medical Group Management. They actually have a consulting division, and they do work with small practices. I had asked them for some examples for a presentation that I'll be giving later. Can you give me some examples of how you've helped small practices? Because as a small practice, we wear so many hats. It's hard to be master at all of them. And so occasionally it's helpful to reach out and tap in and to get some outside expertise. And so one of the four examples they gave me was a practice that was having some issues. They came in, they looked at kind of their processes, what the training kind of knowledge and skill set that was required to do it. And they dramatically increased the financial performance of the practice. But let's say, you're kind of close, but not quite there. There may be another practice. So if you have relationships in your county medical society, and if they have a committee that does that, or sometimes if you talk to the executive director, say, hey, I'm having an issue with this particular point, they might say, oh, Dr. So-and-so, his office does really good. And so, so that is the way. Also with the MGMA, they actually have state memberships that have local memberships. And there's some great networking that can go on. And actually, as I think about it, that is probably the one that most likely might pay a benefit, would be to network to see who else in the community, because it's highly unlikely that you're the only practice that's having that problem. So you want to emulate best practices, not worst practices.
Got it. So when you get that information from your peers, either in state medical societies or in other associations, or just neighbors around you, how do you take that to your staff and sort of incentivize your staff members to sort of improve or educate them on how to sort of get those clean claims in, and how to decrease that denial rate?
Well, I think from the standpoint, if you have several, first of all, you have to find out what is the root cause of why there's not a clean claim. So is it a point that's common to all of your employees, or is somebody, they're not having a bad day, they're kind of having a bad life, and they just haven't quite gotten it together? And so if it is one employee that is suboptimal in their performance, then look to see among your other employees who's kind of the best, who is a natural leader. And it may be not overall, may be for one process step. And so I think it's looking to see, where is the deficit? Is it knowledge, skill? Is it motivation, personal time management? And so the things that you can do that are easy, and they're kind of non-financial, they don't have a fiscal note with them, is maybe a preferred parking spot, or for a nominal fee, whoever has the best clean claims for the month maybe has a small dinner, and whoever has best clean claims for the whole year goes to a nice restaurant that they might not otherwise be able to go to. So there's some things for not a great deal of money that you can do that really motivates people. And you also want to remember that you praise in public, but you discipline in private. And so you want to create a workplace that's considered a good workplace that will help you retain your good employees. And it'll also, from a recruiting standpoint, when you have needs, if someone else is not so pleasant an employer, they might be your local recruiting agency.
Got it. Yeah, I think it's helpful to note that you look for the leaders that are already within, and leverage those folks to sort of improve on the effectiveness of your practice. So Yeah, a nice dinner is always appreciated, I'm sure. Going back to the revenue cycle steps from our last webinar, I did want to ask another question on sort of the claim submission and monitoring process. When you're doing claim submissions and then monitoring those submissions and denials, what are some of the typical problem areas that you found, and are there any tips and tricks that you have found that can rectify or avoid these pitfalls altogether?
Well, I think, one of the things, kind of looking at from a coding standpoint, or the procedure codes, is especially if your practice is primarily E&M, the comment I'm getting ready to make is less applicable. But let's say that there's a procedural component to your practice. And so looking at the CPT codes, is a CPT code that accurately, I'm not suggesting false claim, but are they submitting the claim that legitimately has the highest value? If you are using, if anesthesia is involved, let's say it's a surgical practice, but this comes in with GI and cardiology as well, that sometimes you go in expecting to do one procedure and you have other findings at the time, and the procedure changes. So does the pre-procedure code match the post-procedure code, even internally within that particular physician's claim? But does it also match that of anesthesia? And if there's a facility involved, does it match the facility code? And because all three of those codes have to match, or else it'll be one of the root causes for a denied or delayed claim.
Got it. And further on down in terms of the cycle itself, revenue cycle itself, we have to sort of manage the payments from the payers and collect. What are some of the areas that you monitor for, and what are the difference when you're troubleshooting? You look at your expected values versus your actual payments. Where do you monitor for those differences, and what are the implications for those differences?
Yeah, you want your billing system. Let's say that the contract is supposed to pay $50 for an RVU. Now, once again, they're probably not going to collect that. If you collect somewhere in the mid 95% plus or minus, that usually it will meet benchmark. And so, but if you're expecting $50 a unit and they're paying $40, then that's only 80%. And so that's below. So you would want to track those expected payments once again on each claim, but then aggregate them by payer and see how it compares also to your overall practice. So you'll look at it in several different frames, and then you'd want to look on the accounts receivable. And this goes back also to the earlier question, if you're outsourcing your billing. On accounts receivable, you have the date of service, an acronym that you'll see there's DOS. You have a date of payment or posting, which the usual normal acronyms, DOP, you see that a lot. So, but then if there's a payment, and they're the acronyms, I was looking for one to see if I could find kind of a more standard one. That a lot more variability in what the acronym would be. But on the date of payment, so on a re-aged account, if there is a payment where the insurer pays, some of the companies will start that all over again, and that's where they're re-aging the account. And so you don't really have a good handle from the date of service to the claim being closed as to what that days in accounts receivable would be for that particular claim. And so you want non-re-aged accounts, because you want to be able to compare apples to apples from date of service to the close of the claim.
I think you've mentioned a few terms that I think some of our audience members or many of our audience members are pretty accustomed to hearing. But for those folks who are just starting out, could you describe what the accounts receivable or AR is? And also, what do you mean by aging and re-aging?
Okay, so on accounts receivable, you see the patient on January the 1st. Well, I guess that's a bad example. Let's say January the 15th. And so if it's an office-based encounter, you may collect the whole payment at the time of service and then bill for the patient. But a lot of practices would, let's say on that $50, they would expect the insurance company to pay $40 and they would ask for $10 at the time of service. So the $10 is now a payment that's captured at the time, at your office. But the $40 now is going to be submitted to an insurance company. And so that is now an accounts receivable or AR. And so then you would file the claim and go through the processes. So it takes so many, well, let's say you do the service on January the 15th. Your billing office may not bill it until January the 17th. So that would be the date of posting. And a lot of times there's a little bit of lag there. And then at some point, the payer, the insurance company, would make a payment. Now, Medicare and Medicaid don't pay well, but they tend to pay quickly. Workers' comp tends to pay mediocre, but very prolonged. It takes them a long time in many states. But then on your commercial accounts, you file that claim, and then it may be, some are maybe in 20 days after the service or after the claim is submitted. A lot of them are kind of in the 35 to some up to around 60 days. And I see a lot of variety in that 30 to 60 day window after the service. So in a re-aged account, let's say that the insurance company pays part of it. They only pay $25. And so then if you're looking at your accounts receivable, the clock would start all over. And so you don't know then when the claim is finally closed, let's say 2 months later, that it would look, well, that's egregious. Let's say that they close it a month later at 30 days. So then it's now been 45 days since that date of service. And so, but they're telling you it's only been 30 days if they re-age the account. If you do not re-age the accounts, you know exactly from the date of service to the date that claim is closed, it was 45 days. And so it takes away some of the gaming. That's part of the gaming that goes on
Yes.
with the billing companies.
Got it. So I just want to clarify. So the re-aging is basically they're restarting the clock when it shouldn't be restarted.
Right. And it's impossible to do an apples to apples comparison when they re-age. It's a technique that's not considered best practice. And it's a technique that if they're doing it, that's code for that they're getting ready to game you, probably not only in that, but in other areas as well.
Gotcha. Got it.
It's a red flag.
Gotcha. And so you did touch upon, taking patient payments at the time of service. And, maybe if they have, a balance or that kind of thing a little bit later on. And I think for a lot of us, that's kind of a sticky subject. You don't really want to alienate the patient, but at the same time, you do want to get paid for your work as well. So in trying to collect on these patient payments, how do you balance managing, getting paid, but respecting the dignity of the patient so that they don't feel alienated?
I think most patients do want to pay their claims. Elderly patients, a lot of time don't have, they're no longer working, so their revenue stream is different than it was when they were working, and some of them may still be kind of recalibrating their entry into retirement. But so small balances. I had one lady, I remember she paid $5 a month. We offered after several months to write it off, the balance, and she said no. I pay my bills as best I can, and right now it's just not very rapidly. But for her, it was a badge of honor. And had we written that off, it would have offended her. And so, in trying to help her, it might have alienated her. But you can take, if it's, once again, not so much in the office space, because you're probably doing that at the time of service, but if it's a procedural, allowing them to pay on credit card, and maybe monthly installments, you can set up payment. And a good system will scrub that and give you, if you need to click on a particular patient, a good system will click on it and say, okay, this is the day, it tells you the date of service, this is what was collected at the time of service, this is the expected payment, and so you can kind of track it in those buckets. But let's say that you get to a point, and it's truly a hardship case, that writing off the balance for someone who is kind of beyond their control, it will build goodwill. And I'm not advocating that you write off every balance, but when it's justified, and especially if they've been a long-term patient, and all that will go a long way to enhance your reputation in the community. Not as being easy, but what, they were fair. And I've seen this doctor for years, and I lost my job last month, and the doctor's working with me. So.
Yeah, I think that's much appreciated by the patients, and at the end of the day, we're here to take care of our patients. So that's part and parcel of that. I think we're getting towards the end of our discussion here, but I wanted to ask you sort of an overall question. So what are some of the top line suggestions or recommendations that you have for long-term success for practices in optimizing their revenue cycles?
I think in optimizing the revenue cycle, looking at the practice as analytically as you're able to do, and know how, as you're looking at those key performance indicators, how you rank with your peers. The MGMA, for instance, can give you geographic differences between, they have what they call major regions, of which there's 4 in the country, but they have a lot of minor regions, and sometimes you can get state level data, and if you can get that, that's great. But they can vary it certainly by specialty, but by size of practice. I think they have like a 1 to 3 doctor breakout, and a 4 to 5, and kind of in the 6 to 10 and greater than 10. They actually have some of the buckets are like practices from 25 to 50 and over 50. I find a lot of those have the dreaded asterisk by them, because that means that they did not have at least 10 responses to that, and so they're not able to report a value. The values that you see will be several months old. Some of them may be a year old, but at least they give you an idea of what folks in your peer group, the experience that they're having.
Well, with that, I'd like to thank you, Dr. Lockhart, for joining us today for this engaging conversation that we've had. And I think you've given us a lot of your wisdom in how to manage your revenue cycle. So appreciate that.
Well, thank you for the opportunity. I'm sorry that the screen's been frozen, and hopefully the thunderstorm that's going on outside didn't blow everyone's eardrums out. So it was a pretty big strike of lightning close. So sorry about that.
And with that, I thank you for joining us today for our discussion, and have a great rest of your day.
Thank you for the opportunity to participate.
Thank you both for your time today. I would encourage anyone else, if they have other questions, to post them on the discussion board, and they can be answered asynchronously by Dr. Lockhart. If anyone is interested in more in-person events or opportunities, please check out this upcoming event on saving time in your practices. Thank you, everyone, and have a wonderful day.